Hi, I'm Mark Drasner, the Clinical Chief of Cardiology at UT Southwestern Medical Center. Thank you for joining me. Absolutely delighted to be discussing one of my favorite subjects, the diagnosis, in particular, the clinical assessment of patients with heart failure. I have no disclosures for this presentation. As we begin, I think as you're preparing for the boards, it's a good idea to focus on the Class 1 or Class 3 recommendations in particular. I'll start the talk just by showing you the Class 1 recommendations for the history and physical examination. The first one indicates that you should perform a thorough history and physical to identify cardiac and non-cardiac disorders or behaviors that might cause or accelerate the development or progression of heart failure. You should perform a 3-generational family history to help you establish a diagnosis of familial cardiomyopathy, and that volume status and vital signs should be assessed at each patient encounter, including an estimate of the jugular venous pressure, the presence of peripheral edema or orthopnea. And if you go to the 2013 guidelines from which this was taken, there's a nice table, Table 6, that reviews the key findings of the history and physical examination that might be worth your perusal. So with that as background, this will be the outline of the talk. We'll talk about assessing the hemodynamic status. We'll talk about prognostic information and risk stratification provided by the clinical exam, and then we'll focus on laboratory and diagnostic testing. And what I'm going to do is I'm going to throw in a sprinkling of clinical and board pearls to kind of spice this up and make it even more interesting. So here's the first clinical pearl. These are data from the Copernicus study from Jean Rouleau, looking at the entry level of systolic blood pressure. And what you can see here, this is event-free survival over about 2.5 years. And you can see that a simple measure of blood pressure at study entry is a powerful prognostic tool. On the bottom graph, those are patients who had blood pressures of 85 to 95. And on the top graph, you can see those who had blood pressures, systolic pressures of 125. Look how powerful you can risk stratify your patients even with a simple measurement of systolic blood pressure. Well, let's talk about using the clinical exam to assess hemodynamic status. Many of the viewers are probably familiar with Lynn Stevenson's approach to so-called 2-minute hemodynamic assessment, where she advocates placing patients in one of these 4 quadrants based on whether the left ventricular filling pressure is normal or high, so that would be dry or wet, and whether the cardiac index is normal or low, that would be warm or cold. So for example, profile B, those are patients who are warm and wet, normal cardiac index but high filling pressures, and what I call the dreaded profile C. These are patients who are cold and wet, a low output with high filling pressures. Now, there's some immediate therapeutic implications of using the Stevenson classification. If you have a patient who's profile B, and if there's any justice in this world, they should respond to diuretics. Whereas the dreaded profile C, those are individuals where you're going to have to make a difficult decision of adding something in addition to diuretics, whether that's inotropes or vasodilators. So if you're in the board situation and also in real life, and you think the patient is profile B, I would advise you to not add inotropes at that point. Just go with the diuretics and reserve inotropes or vasodilators for people who are more likely to be in profile C than profile B. I think that's an easy testable question in the board setting. Well, then how do we decide which of the quadrants our patients are in? We'll first focus on the filling pressures. How do you estimate left ventricular filling pressures, which I should say oftentimes the pulmonary capillary wedge pressure is used as a surrogate for the left ventricular filling pressure? How do you do that by signs and symptoms? And I will emphasize that a card-carrying advanced heart failure transplant cardiologist absolutely needs to get good at this. Well, when we queried the ESCAPE database, it turned out that of all the parameters available in the history and physical, only 2 were associated with an elevated filling pressure. Here, a wedge pressure greater than 30. And those 2 were a jugular venous pressure greater than or equal to 12 centimeters, or the presence of orthopnea. You can see the odds ratios here, both were significant. So if you want to boil it down and get to estimating volume status, at least based on the ESCAPE database, you can look at the neck veins and find out whether your patient has orthopnea or not. Now, there's some dynamic maneuvers that you can do as well. The first I'll highlight is the abdominal jugular or the hepatojugular reflux. This is a classic study from Dr. Evie back from 1988, where he assessed patients based on the abdominal jugular reflux. And these are the various patterns on the left-hand side of the jugular veins. You can have a flat jugular vein, you can have it increase and then come back to baseline quickly. Both of those patterns were considered negative. If you pressed down and the jugular venous pressure stayed high for 10 seconds, that was positive. Or if it went up and came down, but when you let go, it still went down another 4 centimeters, that also was considered positive. On the right-hand side, you can see how you can risk stratify your patients in terms of whether their pulmonary capillary wedge pressure is elevated or not. Those who had an positive hepatojugular reflux on the right-hand side had much higher filling pressures than those patients who had negative. There was some overlap, but you clearly can see that the presence of hepatojugular reflux suggests that the left-sided ventricular filling pressures as measured by the pulmonary capillary wedge pressure will in fact be high. Another dynamic maneuver is performing the Valsalva maneuver. Here you can see on the left-hand side, patients will have phase 1, that's a direct increase of the arterial pressure due to transmission of increased intrathoracic pressure. What you do is you ask your patient to bear down as if they're straining to have a bowel movement. In all patients, the first 2 beats, the pressure should go up. But phase 2 then happens in the presence of normal left ventricular filling pressure. The systolic blood pressure starts to decrease. Now, because this decrease is due to a diminishment in the return of left ventricular filling, in the presence of high left ventricular filling pressure, you get the pattern that's shown on the right-hand side. You have phase 1, the blood pressure goes up, typically 10 millimeters, and then as long as the patient is bearing down for 10 seconds, during that 10 seconds, the arterial pressure, will stay up, and then when they release the strain, then it comes down. And so this response, this is called a square wave. The blood pressure increases as the patient bears down and will still stay elevated by 10 millimeters throughout the strain phase. So it's very easy to stratify your patients based on the Valsalva maneuver. I won't go into the literature supporting this, but suffice it to say, this is among the strongest evidence in the literature in terms of detecting elevated left ventricular filling pressures. Now, it's interesting that the clinical characterization of heart failure symptoms really had not changed for many decades. This is the classic Framingham New England Journal paper, and in here they talk about major and minor criteria, and the criteria included PND, orthopnea, dyspnea, and exertion. These are the same symptoms that we're talking about many decades later. Our group, spearheaded by Dr. Thibodeau, my colleague, noticed that many of our patients were coming to us telling us that they were getting short of breath when they put on their shoes. And we had an intense debate among our group about whether this in fact could be a symptom of heart failure, and we set off to study it, a symptom that we're calling bendopnea, dyspnea within 30 seconds when bending forward, for example, when putting on shoes. The characteristics of bendopnea in this observational study was that it was fairly frequent. Almost 30% of the 100 or so subjects had it. It happened very quickly. The median time was 8 seconds. And when we tested the patient before and during the catheterization for the presence of bendopnea, there was 100% agreement. It was reproducible. These are the key data from that publication. This is looking at the pulmonary capillary wedge pressure in those who had bendopnea in red versus those who did not have bendopnea in blue, both in the sitting and bending position. And you'll note that those who had bendopnea, even in the sitting position, had higher wedge pressures. You'll note that the wedge pressure went up comparably the same slope in both, but because they started higher, the bendopnea people ended higher. And so we postulated that there may be a dyspnea threshold, that the patients with bendopnea cross that threshold because they start with a higher wedge pressure, whereas those who do not have bendopnea start lower, and so they never get to the dyspnea threshold. Now, it shouldn't surprise anyone that there's a coupling between bendopnea and elevated filling pressures. These are data from the VMAC looking at response to vasodilator therapy. This is looking at the wedge pressure on the left-hand axis, showing that as the vasodilator was applied, the wedge pressure went down. And then on the right-hand side, this is looking at moderate or marked improvement in dyspnea. So as the bars go up, that means the patient is less dyspneic. And what you see is that as the filling pressure comes down, there is a reduction in the dyspnea in this trial, similar to what we're seeing with bendopnea, this coupling between dyspnea and elevated left ventricular filling pressures. Okay, here's our second clinical pearl, Kussmaul sign, an inspiratory increase in the venous pressure. And this important publication looked at the presence of Kussmaul sign and demonstrated it was associated with reduced survival. These were 90 patients who were referred for heart transplant. 43% had an inspiratory increase in the invasively measured right atrial pressure. So this is not on exam. This is actually a cath lab-based study, but it's the same idea looking at Kussmaul physiology. And what you can see on the Kaplan-Meier curve is that those patients who had Kussmaul sign had a much lower survival compared to those individuals who did not have Kussmaul's. Now, I thought it'd be interesting to give you an example of Kussmaul's. With modern day technology, of course, you could get a video like this. So let me play this really quick.
Okay, please take a slow deep breath in. Good, and out. And another breath in. And out. Thank you.
Hopefully you saw that the venous pressure rose as the patient took a breath in. A very clear demonstration of Kussmaul's. So it's a nice segue to get to the jugular venous pressure. And what I'd like to cover is how to measure it, and also the relationship to left ventricular filling pressures against the wedge pressure. I'll point out that Jay Cohn, who was the founder of the Heart Failure Society of America, he was prescient when he said back in 2001, the jugular venous pressure, JVP, is the single most important marker of the status of intravascular volume. So how do you estimate it? What you want to do is find the jugular venous impulse, estimate the vertical height above the sternal angle of Louis, and then add 5 centimeters. So in this case, for example, if there was a 4 centimeter height above the sternal angle, you would add 5 and then say the jugular venous pressure was 9 centimeters. Now the purist, if you want to convert from centimeters of water to millimeters of mercury, you multiply it by about 3/4. And so in this case, you'd multiply 9 by 3/4 and come up with a right atrial pressure that would be short of 9. Now, how are the tips? What are some tips for measuring the jugular venous pressure? And I'll refer you to this nice publication my colleague and I had in JACC Heart Failure in 2018, talking about the clinical examination. These are some of the tips we highlighted. Inspect both sides of the neck. Sometimes you'll see it on the right side, sometimes the left. The external jugular vein is okay to use. Just confirm it's spirophasic. Assess at various degrees off the horizontal, whether that's supine 30 or 45 degrees, and then sitting. An important clinical pearl is that high JVP can be missed at lower angles. So you should always inspect the neck at least once with the patient sitting upright, because the high ones can be missed at lower angles, and the high ones are the very ones that you don't want to miss, of course. If you can't see the JVP even in the supine position, then press on the abdomen or the right upper quadrant. Take advantage of the fact that the JVP may increase when you press down, and it might allow you to see it. And then the most common question I get on rounds is when I show my trainees a impulse, the question is that carotid or venous? That's the most common question I get. And there are a variety of ways you can try and distinguish, but the one I think is most helpful is apply pressure 1 to 2 inches below the impulse to distinguish from venous from arterial. And let me show you this clip here to give you a nice example of that.
So we see an impulse here. The most common question is it a carotid or a venous waveform? What you do is you take your finger and you press below it. And if the impulse goes away, then you know it's a venous waveform. You'll see when I let go, the waveform returns. So that tells us that this is a jugular venous impulse and not a carotid artery impulse.
Okay, so that's a very nice, clear demonstration, hopefully visible to all of you. And as another tip, I've learned it does take a little more pressure than you anticipate, having done this with a number of my trainees now. So you do have to apply some pressure as you try to obliterate the jugular vein. Okay, now a very important concept is, why are we interested in the JVP, which reflects the right atrial pressure, if what we're trying to do is estimate the left-sided filling pressure? And I think the reason is shown here. This is 1,000 subjects who underwent right heart catheterization. And what we did is we characterized the patient based on whether the wedge pressure was low or not high, defined here as less than 22, or high, defined as greater than 22, and whether the right atrial pressure was high, defined as greater than or equal to 10, or less than 10. So of the 1,000 subjects, 474 had a high wedge pressure and a high right atrial pressure, 47%. And another 312, or 31%, had a low wedge pressure and a low right atrial pressure. We call those quadrants concordant, meaning that the right-sided filling pressures mirror the left-sided filling pressures. They're a faithful recapitulation. The right side is a faithful recapitulation of the left side, that would provide meaningful information about the wedge pressure just by examining the neck veins. Now you'll note though that there are people in the other two quadrants. These are discordant groups where the right side filling pressures do not mirror the left side filling pressure, and they will lead you astray in terms of if you're trying to estimate the left sided filling pressure based on the neck veins, you will be led astray. You will have an inaccurate estimate of the wedge pressure by going by the neck veins. And that happened in this series 21% of the time. Well, an obvious question is, well, how common does this happen in other series? And we have now looked at several large groups, and it's somewhere between 20 and 30% of the time, the right side filling pressure, the right atrial pressure, is not a direct measure of the left ventricular filling pressure. And so that's an important caveat to remember as you're trying to estimate left-sided filling pressures by the neck veins. Now, those discordant groups, you can then think about sub-phenotyping people. We call patients who have a low right atrial pressure with a high wedge a compensated RV pattern. Those patients, the risk is that you're going to look at the neck veins are down, and you're going to erroneously believe that the patient is compensated, that is, that their wedge pressure is not high. This other group is the one that particularly intrigues me, the right-left equalizer group. This is where the right atrial pressure is higher than expected for a given wedge pressure. For example, a right atrial pressure of 18 with a wedge of 20. The risk there is you're going to see the neck veins up. You're going to say, Drasner says the neck veins are the best thing to use to estimate filling pressures, and you're going to escalate your diuretics, thinking the wedge pressure is much higher, and you're going to be at risk for over-diuresing your patient, leading to hypotension, renal failure, and worse outcomes. And I'm not, for the sake of time, will not show you the data, but there are observational data that do suggest that individuals in this right-left equalizer group, in fact, are at risk of renal failure and worse survival associated with this hemodynamic pattern. So if you're given a scenario on the boards or in real life where response by your patient is not as expected based on the JVP assessment, remember that the neck veins may be discordant from the wedge pressure, and in that situation, you may need to define the hemodynamics by placing a right heart catheter. Classic situation, your diuresing patient, the neck veins are up, creatinine is rising unexpectedly. Maybe that patient is a right left equalizer and the wedge pressure, they're really not as wet on the left side as you think they are. Okay, here's another clinical pearl. Pulsus alternans. This is a case where the blood pressure alternates every other beat. You have a strong beat, strong, weak, strong, weak. Now you'll note this, if you put your hand on the radial artery and if someone has bigeminy, it will also feel strong, weak. But in this case, the weak beat is occurring not with a PVC, but is coming on time. So it will be a regular strong, weak alternation, whereas ventricular bigeminy, the weak beat will be coming early, will come early. And I love this quote from Marriott, from his bedside cardiac diagnosis book. Pulsus alternans. It is known as one of the two death rattles of the left ventricle, the other being an S3 gallop, and should always be looked for in persons with suspected dysfunction of that ventricle. And I would note that you're not going to be able to pick this up by looking at telemetry. You actually have to put your hand on the radial artery, unless you have an A-line in order to pick up this important sign. Okay, I spent a lot of time talking about estimating filling pressures. We talked about orthopnea, endopnea, JVP, HJR, the Valsalva blood pressure response, edema and ascites if present. But I would note that RALs were not on the list. And I do think that's another very testable point on the boards. If they give you a patient who has, the lungs are clear and there's no peripheral edema and there's no ascites, but they tell you that the neck veins are up and maybe they tell you the patient's orthopneic, you're going to want to say that the patient has elevated filling pressures because the RALs are insensitive. The absence of RALs does not mean the patient is dry. Similarly, patients can definitely have high wedge pressures even if they don't have peripheral edema. So don't get fooled by that. Let's move then to this side of the equation, cardiac index. How do you tell if your patient has a normal or low index? Are they warm or cold? Here are some clues. If the patient's sleepy or fatigued, if they have cool extremities, of course, make sure it's not just one leg and exclude peripheral vascular disease. And then you can measure what's called the proportional pulse pressure, if that's less than 25%. That's just simply the pulse pressure over the systolic blood pressure. In this example, The blood pressure is 90 over 78. That's 12 over 90. That's 13%. That's low. Typical blood pressure, 120 over 80. Pulse pressure would be 40 over 120, 33%. That would be over 25%. A normal blood pressure would suggest that your cardiac index is normal. So if you're given a patient with a low pulse pressure, proportional pulse pressure, at least think about whether they may in fact have a low cardiac index. Now, when we queried the ESCAPE database, it turned out that no single parameter was associated with a lower cardiac index, except for the overall gestalt that the patient was cold by the investigators. In that database, if the investigator thought the patient was cold, the measured cardiac index was 1.75. If they thought they were warm, it was 2. But there was no single parameter underlying that overall gestalt that was associated with a low index, at least in this database. A very important point is that the clinical exam has low sensitivity for detection of a low cardiac index. Here we're looking at the cool extremities proportional pulse pressure, or this overall gestalt, and you can see here that the sensitivity is very low. And I will add here that on a routine basis in the hospital, a patient whom I think is warm has a low cardiac index when I send them down to the cath lab. So I've started summarizing that observation by saying this: if they are cold, they are cold. But if they are warm, they may still be cold. If they are warm, they may still be cold. I think that's important to remember as you're not only taking the boards, but as you're evaluating your patients and trying to decide whether you think they're well perfused or not. So for those of you keeping score, I've just highlighted 2 hemodynamic causes of worsening renal function that I would expect an advanced heart failure cardiologist to know. The first is that the right atrial pressure may be disproportionately high relative to the wedge pressure. That is, they're in the right-left equalizer group. The neck veins are up, creatinine rising with diuresis. I'd want you to at least think about whether maybe the right atrial pressure, the JVP, is not reflecting the left side filling pressure. The second hemodynamic cause would be a low cardiac index, even though you think the person is warm. If they're warm, they may still be cold. How often does that happen in the hospital? You're diuresing a patient, you think they're well perfused, you may not even consider the fact that they have a low index, cardiac index. But remember, our clinical exam has low sensitivity for detecting a low output. And these are just some of the limitations of the physical exam that we have to be aware of. There's nothing magical about the physical exam. It's a diagnostic test, and we want to know the strengths and limitations. And these are 2 of the limitations as we try to assess our patients with heart failure. All right, let me move to the prognostic information and ability to use the clinical exam to risk stratify our patients. This observation from Dr. Greg Fonerl many years ago was important. And what he demonstrated looking at outcomes after 2 years of patients with advanced heart failure after hemodynamic guided therapy is he demonstrated on the right-hand side, you see that there was no risk stratification based on whether the cardiac index was above or below 2.6. Same mortality rates. It was the individuals who had high filling pressures, here defined as a wedge pressure greater than 16, that had increased mortality compared to those who had a wedge pressure that was 16 or lower, suggesting that it is congestion, elevated left ventricular filling pressures, that provides the prognostic utility rather than a low cardiac index. Well, let's move to chronic systolic heart failure. These are data from the SOLVE database. We queried the entry assessment of the presence of jugular venous distension or not, and looked at the freedom of death or heart failure hospitalization. And what we demonstrated that those who had elevated jugular venous pressure had a worse outcome after follow-up compared to those whose neck veins were flat. And then in multivariable analysis, we showed that the presence of either jugular venous distension or the third heart sound was associated with a significantly increased risk of death, 17%, or heart failure hospitalization, 43%. And this was a multivariable analysis adjusting even for ejection fraction, New York Heart Association class, sodium, creatinine, diabetes, as well as beta blocker use. So pretty impressive that the clinical exam, even after adjusting for these other important parameters, still conveyed prognostic utility, suggesting that congestion is an important risk factor for our patients with heart failure. Most recently, the Paradigm investigators extended these observations This was published in Circulation last year. And what you're seeing here is the number of signs of congestion, here defined as jugular venous distension, third heart sound, rales, or edema, looking at a variety of outcomes, both for those individuals who were randomized to enalapril in the blue or the ARNI in the red. And what you can see is that the composite endpoint of cardiovascular death or heart failure hospitalization, that as the number of signs of congestion went up, the incident rate of death or heart failure hospitalization increased. That was also true of the underlying components of the composite, cardiovascular death, as well as heart failure hospitalization, as well as all-cause mortality. I'm not going to show you, but they then adjusted for other parameters, including natriuretic peptides when available. And they showed that still, even in multivariable analysis with adjustment for natriuretic peptides, clinical congestion remained associated with adverse, as a risk factor for adverse outcomes. So I think it's pretty compelling data now that congestion is bad for our patients. And when you see a patient persistently congested, you have to worry about their subsequent outcome. Well, that's in chronic heart failure. What about in decompensated heart failure? And I want to emphasize that the clinical exam can be used for serial monitoring, since it's very easy to perform serial examinations. And so this is something very amenable to that. Well, first, in the decompensated space, admission Stevenson profile has been shown to be associated with subsequent mortality. Here you have the reference group of profile A, and you can see that those who were in profile B or C had worse outcomes after a year and a half of follow-up. The NHLBI Heart Failure Network, using dose and caress, came up with this risk composite called orthodema. Orthopnea, you got these points if you had greater than or equal to 2 pills orthopnea, and then edema. You can see the range is 0 to 4, and they categorize as absent, low, high, high being 3 to 4. And what you can see on this graph here is that the discharge orthodema was associated with 60-day outcome. This is looking at those who had the high score, the 3 to 4, and you can see that the endpoint was significantly increased compared to those who had either no orthopnea, no orthodema, or had a lower orthodema score, suggesting that congestion at the time of discharge is a bad player. The best data, though, in this space, I think, come from the Everest investigators. This was a trial of 2,000 subjects. This is only looking at the placebo arm, followed up for about 10 months. These are data from Dr. Georgiati before he passed away, and looked at the congestion score, heart failure, hospitalization, death, or the composite. And I'll focus your eye on these cells. Look how powerful discharge congestion is. If the congestion score, I should say, included orthopnea, JVD, or edema, each on a scale of 0 to 3, and look at how powerful it is. If you have more congestion, your risk of death was over 2-fold increased over the follow-up and under 1-year follow-up. And the composite also was about 50% increased if you had the composite, again, of having 3 or more markers of congestion. So we've seen both in the chronic ambulatory space, and now we've seen convincingly in the acutely decompensated hospitalized space that congestion is associated with adverse outcomes. And then finally, you can extend it even beyond discharge. These are data looking at the follow-up visit 4 to 6 weeks after hospitalization. Again, a different congestion score, but same idea, using orthopnea, JVD, edema, weight gain, increased diuretics. You got a point for each of these. And then look how powerful this is at this follow-up visit at your subsequent 2-year mortality. If you had none of these 5 markers of congestion, your 2-year mortality was only 13%, whereas if you had 1 or 2 of these, you had a 33%, and if you had 3 to 5 of these clinical markers of congestion, your risk of death was 59%, over 4-fold higher. So very compelling evidence that congestion is associated with subsequent adverse outcomes. Here's the last clinical pearl, this idea about balance of body weight, which I really like as we talk about congestion. Of course, if patients present with edema or ascites, they'll get heavier, but some patients will present lighter with anorexia cachexia. As you know, heart failure is a cachectic promoting illness with gut congestion, inflammatory states. Patients can sometimes present to you just like as if they have cancer, like a cancer victim, profoundly wasted. And then there are some individuals who present to you saying that their weight hasn't changed, but they have swollen legs. And when you diurese them, you unmask the fact that they lost 20 pounds. They just didn't know that because they happen to retain volume at the same rate as they were losing body weight. So I think it's really interesting as you think about body weight. The clinical pearl is that it's a balance between volume retention and true body weight loss. And patients can present in one of three phenotypes: cachectic looking, swollen, or they could present with saying they haven't lost any body weight, but they're swollen and their true body weight loss was masked as they accumulated peripheral edema. All right, let me pivot then to the closing aspect, which is the laboratory and diagnostic testing. I'm going to take you back to the 2013 guidelines, show you the class 1 and 2A recommendations. Initial laboratory panel should include a CBC, a urine analysis, electrolytes, including calcium, magnesium, BUN, creatinine, glucose, lipids, LFTs, and TSH. And then class 2A, meaning you should do this, reasonable to do this, hemochromatosis, screen for that with a ferritin, HIV, if clinical suspicion, look for rheumatological amyloid or pheochromocytosis. 12-lead EKG in all patients presenting with heart failure, and then a chest x-ray for suspected acute or new onset heart failure. So if you're in the board situation, new onset heart failure, don't forget about getting the EKG chest x-ray, as well as the kind of the routine battery of laboratory tests. Now, in terms of assessing left ventricular function, the guidelines do recommend the 2D echo with Doppler, but they make the important point that you should repeat assessment of EF if the patient has a significant change in the clinical status or therapy that may impact cardiac function or for consideration of device. But you should not routinely repeat measurement of LVEF. It's a class 3 recommendation. So if on the boards they give you a patient who has been maximized on GDMT for years and has no change in the clinical status, and they come to you in the office setting, you do not want to get a repeat ejection fraction for no reason. It's a class 3 recommendation. And then finally, biomarkers. Biomarkers were covered in the 2017 guideline. I'll refer you to that for full details, but I'll emphasize for diagnosis that there's a class 1 recommendation for getting BNP or NT-bone BNP for the ambulatory patient with new onset dyspnea, and then very solid data in the emergency department, patients presenting with acute dyspnea. You also want to measure BNP or pro-BNP in that situation. So if you're on the board, setting and a patient presents to the ER acutely dyspneic, you should order the BNP or pro-BNP. I'll leave this for later talks, but you do not want to target your therapy to these levels. So serial measurement of natriuretic peptides to adjust your therapy, that is not currently recommended based on the data set we have, but for diagnosis of heart failure and for some risk stratification, it is indicated. Okay, so in conclusion, we covered clinical congestion, card-carrying advanced heart failure transplant cardiologist. You absolutely need to know how to assess this. JVD, HJR, bendopnea of the Valsalva square wave, and orthopnea. We talked about prognostic utility, very strong data, both in the ambulatory setting, in the hospital setting, the discharge, as well as subsequent outpatient clinic visits. Low cardiac output, you want to know how to assess clinically, but you also want to know the limitations of the clinical exam, both for congestion. Here I'm referring to the right-left equalizers, where the right-sided filling pressures are higher, as well as the compensated RV pattern, where the right atrial pressure may not be as high as the wedge pressure, as well as the limitation of our low sensitivity for detecting a low cardiac output. If they're cold, they may still be warm. When to order and when not to order. The natriuretic peptides just covered, and don't forget to get the basics, the chest x-ray. I should have included the electrolytes, and then we talked about echo initial assessment, but and repeating it if there's been a change in clinical status, or if there's a implementation of a therapy that may recover ventricular function, or you're considering a device, but not routinely. Just don't get a serial echo for no reason. And then finally, the key clinical pearls. Don't forget about the importance of systolic blood pressure, the intrastory increase of the venous pressure, the Kurzweil sign as prognostic utility, Pulsus Alternans being a death rattle, and then we talked about the balance of weight. And with that, I will conclude. Thank you for your attention.